Cosmetics or cancer?
What are we really feeling?
I'm Emily Barraquette.
I'm Taylor Benoit.
I'm Megan Cook.
I'm Tara Kroshko.
And I'm Elise Ma. Before we begin our presentation, we would like you to think of a few concepts. If you are an oral health care professional, have you ever asked your patient if they've had facial cosmetic procedures? Have you ever felt something outside normal limits during an appointment and thought it might be the result of a cosmetic procedure?
For the purpose of our presentation, we decided to focus on lip and dermal fillers in the head and neck region, excluding Botox.
During our presentation, we will define lip and dermal fillers, list the materials used in dermal fillers,
Recognize the clinical characteristics of dermal fillers. Describe the importance of asking about cosmetic procedures on a medical history form.
Compare the distinguishing features between dermal fillers and potential oral pathologies, as well as discuss the risks associated with dermal fillers.
According to the American Society of Plastic Surgeons in 2015, the overall number of minimally invasive cosmetic procedures has increased by 144% since the year 2000. We can only imagine how much it has continued to increase since then.
This exponential increase has left healthcare professionals in the dark about the unintended consequences of these cosmetic procedures. With cosmetic procedures on the rise, oral health professionals want to know what's the impact.
Our research evaluates the impact of these cosmetic procedures on our scope of practice.
Since oral cancer screenings are a very important step within our scope of practice, as well as gathering health history and radiographic interpretations, we want to know what we can do to stay on top of this trend.
What is a dermal filler? A dermal filler uses filling agents with volume-occupying properties. They restore lost fullness in the area of injection and ideally have long-lasting soft tissue augmentation.
Dermal fillers should be biocompatible, non-immunogenic, fast healing, easily applied, and with long-term results.
So there are two different types of dermal fillers, both semi-permanent and permanent options, and they differ based on their materials. The semi-permanent fillers like collagen, polylactic acid, and hyaluronic acid are metabolized enzymatically or phagocytized. Depending on the amount of filler used, they lead to minimal histological reactions after 3 to 24 months. Permanent fillers, on the other hand, like liquid silicone and polymethyl methacrylate, or PMMA, are composed of particles with irregular surfaces, which cannot be phagocytized. Therefore, they can become surrounded by fibrous tissues.
As you can see, fillers can last anywhere from 2 months to 3 years and can even be permanent depending on the material used. For example, hyaluronic acid is a very common filler and it lasts 4 to 12 months.
Physicians, nurse practitioners, registered nurses, dentists, and international medical doctors can administer dermal fillers. The licensing is provided by the Canadian Board of Aesthetic Medicine. This specific certification for injectables, including filler and Botox, is a 2-day comprehensive course which provides theory and hands-on practice. The course is available at multiple locations in Canada, the US, and Dubai.
For dentists in particular, after taking the certification program, they must also have approval from their regulatory body to perform dermal fillers. Currently, provincial regulatory bodies such as Nova Scotia, Ontario, and Alberta will allow dentists to perform dermal fillers. However, the BC Dental Association does not.
Now I'm going to talk about some characteristics of dermal fillers. Common locations they are seen on the head and neck regions include the vermilion border of the lips, the neck, the forehead, and the nasolabial fold. If the fillers are done correctly, it should not be obvious. Lip fillers often have a pillowy effect, and any filler placed in the head and neck region ultimately removes wrinkles and creases. These fillers are typically only palpable in the lips, which feel like small, firm, movable nodules. In the face and neck, however, the skin may feel firm, but it is often difficult to detect.
Generally, patients tend to see their oral health professionals more often than their doctors. An oral health professional's scope of practice primarily involves the head and neck, therefore it is likely easier for one to see and note changes in the head and neck region. Whether these changes are intentional, such as dermal fillers, or unintentional, such as lesions or head and neck cancer.
As a baseline, an intra and extraoral exam should be performed at each visit to help update this data. Patients may receive dermal fillers between appointments, which may be noted in these exams. In addition, if a patient has received fillers in the past, it is important to keep up to date to make sure nothing of concern has developed. Apart from oral health professionals completing extra and intraoral exams, we believe it is equally important for the patient to be provided with the tools to monitor their own oral health.
With all of the information we have gathered and researched, we recommend that dental clinics start to ask about dermal fillers on their medical forms and to think about asking this question during regular oral cancer screenings.
This is a sample of what question we think should be added into your medical history forms. Have you ever received dermal fillers in the head and neck region? If the patient answers yes to this question, this should prompt the clinician to ask further questions, such as, in what area was the filler injected? How recently was the procedure done? And what type of material was used?
Due to this topic rising in popularity, there is not a lot of high-level evidence in the literature. However, we would like to present to you 3 different cases where asking the patient about fillers was beneficial. These cases also highlight some of the potential risks associated with fillers in the head and neck region.
The first case we have here is a 54-year-old patient who was referred to the outpatient oral diagnostic clinic in the Department of Dentistry at the University of Taubaté in Brazil with a chief complaint of firm and mobile balls on her face. The patient did not report feeling any pain. There was no interference with mastication, but the patient did not like the round appearance of her face. During medical history, the patient denied having any facial aesthetic procedures. The nodules were noticed on palpation, as seen in the photo on the left, and were visible through intraoral examination as covered by healthy mucosa with irregular, fibrous texture. Based on clinical examination, neurofibroma or salivary gland neoplasms were possible diagnoses. Radiographs, an MRI, an ultrasonic examination, biopsy, and blood tests were all done for further examination. Although the blood test did return normal, the biopsy revealed a lesion with a whitish surface similar to cartilage. A histopathological exam, which you can see on the photo on the right, of the biopsy showed multiple round spaces which contained very small foreign bodies. With everything taken into consideration, the patient was diagnosed with foreign body granulomas. Upon asking for a second time about aesthetic facial procedures, the patient finally reported having permanent dermal fillers of polymethyl methacrylate in the nasolabial folds 4 years prior. The patient was treated with corticosteroid intralesional injections, which is a common treatment for foreign body granulomas, and the nodules were no longer present for 20 months following the incident.
A 50-year-old patient presented to Kyungpook National University Hospital, located in South Korea, with a chief complaint of intermittent dull pain on the right upper lip area. A month prior, the patient had received lip fillers with PMMA. A few weeks later, the patient returned to the clinic with similar symptoms and was treated with a steroid intralesional injection similar to the previous case. The patient returned again with the same symptoms. Upon palpation, hard nodules with slight redness were observed, and the patient felt tenderness to the right upper lip area. At the time, the patient was provided a diagnosis of secondary infection due to the filler and was treated with drainage and antibiotics. After 3 days, the symptoms did not improve, and a CT scan was taken for further investigation. A 1 centimeter granulation mass was found on the CT scan. It was surgically removed and symptoms subsided. The biopsy showed epithelioid histiocytic granulomas with many multinucleated giant cells, similar to the last case. Since the filler was injected to both the right and the left side of the upper lip, one might wonder why only one side of the lip reacted to the material. The CT scan demonstrated that the lip filler on the right side was injected above the subcutaneous fat, whereas the left side was injected at the junction of the dermis and subcutaneous fat. The article states that there may be a higher risk of granuloma formation when filler is injected into a shallow site, thereby making the skin blanch. This emphasizes the fact that this is a technique-sensitive procedure.
For case number 3, a 48-year-old female patient presented to the Need Al Ghar Dental Specialty Center in Kuwait complaining of a swelling in her right cheek of 2 days' duration. An oral exam did not reveal any obvious dental or oral cause for the swelling. Upon further questioning of the patient, it was determined that 2 days before the development of the swelling, she had a fixed partial bridge re-cemented in the upper right quadrant, and she also mentioned that the upper right canine was slightly tender on percussion. Her past history revealed that she had received filler injection in her cheeks bilaterally about 6 years before. Radiographic examination showed widening of the PDL space around the upper right canine. Drainage was established through an intraoral incision in the buccal mucosa. The yellowish-white discharge was sent for microbiological examination. Culture and sensitivity tests reported Staphylococcus aureus and sensitivity to cloxacillin. The patient was admitted and started on IV antibiotics. The response to the antibiotics was slow, and exudate continued to drain in decreasing quantity. The patient was discharged after 1 week. At the time of discharge, the swelling had decreased considerably, but had not resolved completely. She was given oral antibiotics for a further period until the swelling subsided completely. Injectable materials for facial rejuvenation has reduced the need for complicated facial surgery, but these materials themselves have presented complications like formation of nodules, granulomas, abscesses, and recurrent infection at the injection site. The causes of these complications are multifactorial and may include foreign body reaction or the emergence of a biofilm infection. Case 3 discusses the association between biofilm formation and dermal fillers. Biofilm may be a potential source for many of the late complications like granulomas or abscesses. The free-floating bacteria in tissues become adherent to the foreign body material and thus develops biofilm. Bacteria from dental work, soft tissue surgery, or trauma can activate an infective response of this biofilm.
Now, this may sound similar to you, as we have heard of the same complication with patients who have joint replacements. Some patients who have had joint replacements are required to take prophylactic antibiotics prior to dental procedures to reduce the risk of bacterial infection around the foreign joint replacement. In this case, the dermal filler is acting similarly to the prosthetic joint. A patient's history of use of dermal filler should caution one when carrying out dental treatment in the vicinity of these filler materials. Prophylactic use of antibiotics is debatable, but based on this case, further research should be taken into consideration.
Although we cannot directly link dermal fillers to cancer, there may be a correlation between the two that begins with chronic inflammation as a result of granuloma formation from the fillers. Chronic inflammation produces reactive oxygen species, which are known to be carcinogens.
So, do cosmetic fillers cause cancer? Not necessarily, but this possible correlation demands further research.
What the research has determined is there are risks associated with dermal fillers. One risk is the development into oral pathologies, which are typically noticed when retracting the skin over the mass and may cause facial swelling. This side effect is most likely found with long-term and permanent fillers. Injection site reactions may occur, and symptoms include edema, erythema, pain, bruising, and itching. During the injection, there is a potential for skin trauma to occur where bacteria may be introduced, although with proper sterilization, this incidence should be low.
There is always a risk of infection with any procedure, and cosmetic procedures are no exception. The materials that are used in these cosmetic procedures may also create a hypersensitivity reaction. The symptoms of hypersensitivity and infection may include, but are not limited to, erythema, edema, pain, presence of a non-fluctuant nodule, or an abscess. While many of these reactions occur within a short time frame of the procedure occurring, there are circumstances where there is a delayed reaction. Infection of the injection site, such as an abscess or nodule, foreign body granuloma from injection, as well as migration of the filler material up to 3 centimeters from the injection site.
We recommend for your practice that you stay up to date.
Have you ever received cosmetic procedures in the head or neck region?
We recommend that you ask the questions.
When did you get your cosmetic procedure?
What kind of filler was used?
Where is the filler located on your face?
As mentioned previously, we recommend that dental clinics start to ask about dermal fillers on their medical forms. But as pointed out in the cases, oftentimes the medical forms are not enough.
So what do we ask of you?
We ask that you update patient information,
Ask questions,
And perform oral cancer screenings at every appointment on every patient.
As future healthcare professionals, we realize the prevalence of this trend and the importance of being aware of its impact. We plan to do what we can to stay ahead of the trend and hopefully encourage you all to do the same.
As the head and neck exam is within our scope of practice, we recognize that this responsibility falls on us. Most individuals will only see a doctor when needed, but as oral health care professionals, we tend to see our patients more often, and we are able to take preventative measures towards their health.
Without further research, our current overall concern from dermal fillers is a result of chronic inflammation leading to the release of reactive oxygen species, which are known to be carcinogens.
And lastly, we just want to emphasize the importance of asking about cosmetic fillers prior to dental procedures. Update, ask, perform.
Thank you for listening to our presentation. If you do have any questions, please leave a comment below and we would be happy to answer.